For the n-Lorem Foundation, N of 1 doesn't mean alone because every patient matters. Hope for nano-rare patients and their families has never been more within reach. Visit n-Lorem.org today to donate and make hope possible.
Biogen is proud to host the 2024 Nano-rare Patient Colloquium. Biogen is a leading biotechnology company that pioneers innovative science to deliver new medicines to transform patient lives and create value for shareholders and our communities. They apply deep understanding of human biology and leverage different modalities to advance first-in-class treatments or therapies that deliver superior outcomes. Their approach is to take bold risks balanced with return on investment to deliver long-term growth. Thank you, Biogen, for hosting and supporting the n-Lorem Foundation and our patient community. The 2024 Nano-rare Patient Colloquium is October 30th through 31st in Cambridge, Massachusetts. Visit n-Lorem.org to register today.
Hello, everyone, and welcome to the n-Lorem podcast series. This podcast series is the only podcast series focused exclusively on the needs of nano-rare patients and their families. I'm Stan Crooke. I'm Chairman and CEO of n-Lorem and your host for this podcast series. Today, our special guest is Brady Huggett. He is the feature editor of Transmitter, a journal that focuses on neurodegenerative disorders and neurosciences in general. And before that, I got to know Brady because he's been involved in biotech for almost as long as I have, as the business editor of Nature Biotechnology, and before that, BioWorld. So Brady, welcome. Thanks so much for joining us.
Oh, no, I'm happy to be here as always.
And we're going to do something, well, actually not a little different, 180 degrees different today from normal. I'm not going to be the interviewer. I'm going to be the interviewee, and Brady will do what he does, but way better than I will ever do, which is ask the right questions in the right way. So Brady, I'm going to turn it over to you and we'll go from there.
Okay. Well, so I think it's been about a year since we did a podcast like this, Stan. And I've been watching n-Lorem, and I have a bunch of questions I want to talk about, just the progress that n-Lorem has made. And then at the end, maybe we can talk about the colloquium. But so the first part for me is take me through the progress that n-Lorem has made in the past year. And the one question I want to ask is, how many INDs, and by that I mean investigational new drug applications, has n-Lorem put in overall, and then how many in the past year or so?
We will, I think, file our 21st or 22nd IND in just a little bit. And that incorporates about a treatment opportunities for about 30 patients. And of those INDs, I don't remember the exact number this year, but I would say maybe more than 15 have been filed this year.
Wow.
And we're really proud of that. These are, an IND is not simply a document, it's a statement of an incredible amount of work that gets integrated into the submission that the FDA has to pass or not pass to allow you to treat patients. And each of our INDs are several thousand patients. On average, I think we've had 10, less than 12 people at Ionis. We're now larger than that. I feel very proud of that. But what's important about that number and the way it's growing is that we've demonstrated that we can industrialize this process and that we can start to finish, move rapidly from an ASO discovery program to treating a patient repeatedly. And the other, I think, important aspect of that is we filed 4 INDs in 4 different divisions of the FDA. The 2 neurological divisions, the eye division, and the cardiorenal division. And all the interactions with the FDA have been highly supportive. And that's important news, because even though FDA issues guidance, it's often the case that guidance is interpreted differently by different divisions of the FDA. And that hasn't been the case here. So that's 30 human beings who otherwise would have no hope for help that are in line to get a drug designed for them.
Yeah, you're saying that basically the the message from the FDA has been unified across divisions. You know what you're supposed to do in each division now.
Yes, and more than just unified, I think supportive,
Yeah.
constructive, looking for solutions so that they can help us help these patients. And I think that just speaks to the FDA's commitment to the Nano-rare patient community.
Yeah. Of these patients that have received ASOs, how many have been on a drug long enough so that you can actually gauge progress or gauge benefit?
We will be approaching treating as about 20 patients before, by the end of the year and into next year. And we have 7 patients that have been treated long enough that we can evaluate whether there's benefit that's been observed. And by benefit observed, I mean, prior to starting the program, we agree with the investigator on the treatment goals and the clinical measures we use, and then we compare on treatment to pre-treatment results. So these are tangible, quantifiable, important improvements in patients. And of the 7 patients who are valuable for treatment, all 7 have demonstrated quite significant clinical benefit, which is pretty remarkable.
Yeah. So that's what I want to talk about. So you had this paper published in Nature Medicine. I think it came out in August, right? And it looked at one patient. It was a KIF1A patient, a girl. And this was Susannah. I think this was the first patient that was ever treated at n-Lorem. Yeah. Okay. And
That's
so
true.
I wrote some of this down. So I think before treatment, Susannah was having something like 100 to 290. They're called behavioral incidents or behavioral arrest incidents a day. And after her most recent treatment, I think it was 80 milligrams of the ASO that n-Lorem created, that had fallen down to something like 30 a week, right? Which is remarkable. Yeah.
It is stunning.
The amount of
Yeah.
times that she fell had decreased. Her speech had also improved. And I just, like, before we start talking about what that means for n-Lorem, like, what does that mean in the patient itself to have that much of a lessened burden on the body?
I think it's incalculable, the impact of that on a life, because that mutation is present throughout life. It's wreaking havoc at the molecular level constantly. And even if we're not able to see the manifestations in the whole person, we know they're there. And eventually that will catch up. I think the way I think about Susannah, and many of our patients do unblind us, and so we can talk about Susannah as a person.
Yeah.
Not all of our patients do that. She was essentially wheelchair fast. She was essentially nonverbal. She was progressing rapidly. She had seizures that were extremely intrusive in her life, that destroyed her sleep, made her miserable, and of course, produced then worsening neurological problems. You have a seizure, you get worse. And she was in constant pain. That's another thing that is not emphasized quite as much as will be in subsequent publications. Her chronic pain syndrome was debilitating and, arrested the family as well. I mean, you can imagine watching your child just cry all the time because they're in constant pain.
Yeah.
All of that has improved. And so what does it mean for Susannah? She can walk. She can get up from the floor and say, "Come on, Dad, I'll teach you how to stand up." She can sing the national anthem at sporting attractions, which she's done. She can walk on a basketball court for the Nets game where she was featured. She's getting better. She's not in pain. How do you measure such a thing in anything other than mystical terms?
Yeah. Okay. So the next thing that I wanted to ask you, Stan, is I think what was also shown in this Nature Medicine paper is that, and I think this is probably, people knew this anyway, but the earlier the better as far as treating with an ASO for these kinds of diseases. And I've wondered, like, if n-Lorem has thought about that, like, how is it possible to maybe get access to these patients earlier? And I know you're sort of at the mercy of the patient. You know, they come to you and file an application, but have you considered what to do about this concept of getting ASOs into patients earlier?
Yes. Well, I think it's true for every innovation, intervention that targets the cause of a disease. And I think back to our success rate, I biased us towards success. These are genetic diseases. We know the genetic cause. We're making an ASO to fix the genetic cause, not the symptoms, the cause. And we're treating organs that we really know a lot about.
Mm-hmm.
So 7 of 7 is still surprising. I expected a much higher than normal success rate, but never 100%. And as we're successful, then new patients just appear because all of these patients and families are desperate for help, and the word travels. And for example, with KIF1A, we have another patient on treatment who's much younger than Susannah. And we have Susannah's natural history from the day she was born. And we know that at this stage, at the same age as this young patient, she was about in the same place.
Mm.
So we have a fairly good idea of what to expect for this much younger patient, and we'll be able to address that. So we still are very much at the mercy of the patient and physicians and so on. But what we've learned in these years is that word travels fast, that these are desperate communities. And so word travels fast. And we're now seeing multiple patients being, that we can treat with the same ASO. Sometimes they're very similar ages, and sometimes similar disease, and sometimes very different. And so over time, we'll accumulate, I think, evidence that demonstrates, one, that the central nervous system is far more plastic than we realized. And Susannah is a perfect example of that. She's recovering from function she lost years earlier, but we have lots of that. And two, we'll be able to have at least qualitative information suggesting that early intervention is safe and appropriate and way more beneficial than waiting until a patient is fully symptomatic. The other point that I didn't make is that, again, we think this is perfectly achievable with this technology if you do it right. To date, we've had no ASO-related severe adverse events or serious adverse events, and no ASO-related adverse events.
Mm-hmm.
There are some possibly related adverse events, but these are very sick patients and they will have those. So I think the other piece to that puzzle is to demonstrate that we can do this safely over and over and over again. That then will provide support to parents, patients, regulators, that treating earlier is a good idea.
Yeah, you just mentioned something that I wanted to ask about too. So you had an IND with 3 patients for HNRNPH2, right, to target that gene. Now that was a first. I think that was a first, as far as I was, from my outside observation, that you had more than one patient on an IND. Before that, n-Lorem was like, we're going to get one patient, one ASO, provide that drug for life or free to the patient. So take me through that conversation with the FDA to get 3 patients on one IND and what that has meant for n-Lorem.
Well, I certainly do not and cannot speak for the FDA, so I can only give you my side of the conversation.
Yeah.
The way to think of this is what to do about the N of few. And in the early going, there certainly was meaningful focus on that in our interactions with the FDA. And as a consequence, we had one patient for every IND, and we filed INDs for patients with the same ASO, separate INDs. And there are some times when that makes sense. If the phenotypes are radically different, and they can be, then filing a separate IND, I think, is more appropriate, because the decision to treat or not is based on the characteristics of that patient. What's the risk benefit to that patient?
Yeah.
But we had a number of conversations with the FDA, and we had the opportunity to present our proposed solution to the N of few, which is that we treat what we can afford to treat, the number, And then once we have clinical data, if it turns out that a mutation we thought was nano-rare turns out to be much more common, then we will seek the opportunity to find a commercial partner to do a full development. And this way, we immediately help the patients who we know of that are in urgent need. We build a data package that reduces risk for commercial organizations to take on these small indications. And eventually, the FDA gets a full development program for that ASO. That's what we presented. I certainly am not suggesting that I know what the FDA's response was. But since those meetings, we've had the IND for 3 patients with very, very similar phenotypes. And I think our largest number is an IND for 8 patients with basically the same phenotype.
Yeah, so that I wanted to ask about that as well. So that's for CHCHD10, I think. And that IND had 8 patients on it, and with different phenotypes, I'm assuming. And I think the mutations each mutation is different as well. But because you built an ASO that is not allele specific, that's okay to run it that way, right? I think that makes perfect sense. I could see why the FDA would agree with that.
Well, not exactly. The phenotypes are very similar.
Oh, they are.
But it also works for allele selective ASOs. The 2 KIF1A patients have the same non-pathogenic mutation as well. And so the ASO works for both of them. So I think the general principle that if the phenotypes are similar, and therefore the risk-benefit calculation is similar, then a single IND will suffice to treat more than one patient with the same ASO. From the n-Lorem perspective, that facilitates our helping more patients, and so we're thrilled with it. And from the knowledge perspective, this gives us an opportunity to learn vastly more than we can learn from a single patient. And so I think it's a giant win across the board for science, medicine, patients, regulators, and certainly for n-Lorem.
Yeah, so the idea, my understanding when n-Lorem was founded, that there's this idea that these mutations were so rare that really you might find only 1 or 2 patients in the world. But for something like CHCHD10, that's proved to be larger. And I think if every sick child had their genome fully sequenced, you'd find more, right? Let's say you find 50 in the world, then that begins to look a little bit like a drug development company, if you could provide that much drug, right? And so you're saying the way that that's handled is you would identify the patient population, identify the ASO, and then turn that, I guess, the actual manufacturing of it over to a pharma partner to handle.
Not exactly. So I fully expected, given the inefficiency of sequencing, right now, a tiny fractions of humans have had whole genome sequencing, very tiny. And that means that we really don't know the prevalence of a lot of these very rare mutations and diseases. So I fully expected that on occasion, a mutation that we thought was nano-rare will prove to be much larger. And that's turned out to be much more frequent than I thought. When that happens, we have the opportunity for the first time ever in drug development to rapidly and cost-effectively acquire information about how that drug behaves in a human being. That's tremendously valuable to drug developers because animal models just simply don't predict well enough. But in a human being or several human beings, if we can show that the target's right, the ASO is altering the target, we're seeing evidence of benefit in the phenotype and it's safe, that tremendously reduces risk. And then that means, therefore, that you don't have to discount potential opportunity by 90%, which is what you do at that stage. And that's why these very rare indications just don't ever compute for a commercial company.
Right.
The value just isn't large enough. So if you can reduce the risk, then that means that there are companies that would be interested in the commercial opportunity. We talk to them. and we license them to drug. And that also contributes to our plans for sustainability, because that's an asset that we've just created, which a license would bring in added immediate cash and the opportunity for milestones and royalties as the ASOs developed commercially. So it's the way I look at it is, how can n-Lorem facilitate the biggest win for the most human beings in a safe and effective way? And this is my idea of what is sort of optimal.
So to be clear, though, Stan, you have not actually signed any agreement like that yet.
No, we're actually a couple of years ahead of schedule. We just started bringing these opportunities to potential partners' attention, and we're pleased with the interest, but it's still early. So, you never know until you get a deal done whether it's going to happen. But I've been at this for a very long time, and I'm certainly encouraged by what we're experiencing.
Yeah. So that my next question was going to be, because as you just said, you thought that you're finding more patients than you originally thought you would when n-Lorem was founded. And my thought was, well, boy, the more patients you're finding, the more pressure this must put on n-Lorem to fundraise, to go to philanthropists and say, do you want to contribute? And you're saying that might be alleviated by the ability to outlicense what you've learned from sets of patients to a pharma company, get a license payment from them, maybe some milestones, and that'll help bring money in to continue n-Lorem as a nonprofit.
Exactly. And there are other values that we're creating, that we're also accumulating enough information that we think we can be able to sell those as well, whether it's a novel insight, patents, or whatnot. So that was a part of the plan from the get-go. It's just that we're quite a bit ahead of schedule. And it's great that we are, because the budget is now amounting to some real dollars.
Yeah.
We could very easily file 30 INDs next year, and we're not planning to, because that would mean the budget for next year would be somewhere north of $30 million, and that's tough to raise.
Yeah. So the limiting factor for n-Lorem is not the ability to find new Nano-rare patients. As you said, word of mouth, that's happening for you. It isn't the ability to make the ASO. You can do that. It's funds.
It's dollars.
Yeah.
That is the single limit. Now, I think that's an extraordinarily positive thing to say. I mean, we've proved we can do it. We've proved we can do it on scale. We've proven that we can build systems that industrialize it and protect our patients. We've proven that our systems are generating really high quality information, like you saw in the Nature Medicine paper, that will be valuable to the community. And we've been able to raise the money to grow at a pace that's orders of magnitude than I ever dreamt. And so to, at this stage, have a single remaining challenge of just funding feels to me like a giant success. It also feels like a giant challenge, but it's a challenge that we're ready for.
This is a difficult question, but it occurred to me when I was preparing for this interview. Let's go back to Susannah in the Nature Medicine paper and the vast improvement that she has seen. But it did occur to me that maybe what you would want isn't a giant reduction in falls per day, but falls per day of 0, right? You would want to not have 30 behavior arrest incidents a week. You'd want it to be 0 in a perfect world. And I know n-Lorem's idea is, okay, get the patient, identify the mutation, build the ASO. But is there a step that happens beyond that n-Lorem is thinking about, that maybe the ASO is optimized, it binds better, or that some other step is taken to keep improving Susannah's life?
I think the single most important thing to improve the outcome of our patients is getting to them earlier. I think every drug developer knows that the earlier that you get to a patient, the better the drug's going to perform. And so I think number one, demonstrate that we can do this and do this safely. That will enable us to get to these patients earlier. Step two, be a part of the vanguard driving whole genome sequencing introduction to all newborns. That's the only hope for getting more patients in at the time when we need to see them, which is when the mutation is found. And then third, you have to recognize that each of these patients is really complex. Susannah is now walking. She wasn't walking before. And so what happened? Well, she ran around and tripped and broke her foot.
Yeah.
So exactly what the pattern of enormous success looks like for each patient, and whether anything can go to zero or not, I think really remains a very open question.
Yeah.
And then that's not so much a question about whether the ASO was good enough. That's really, was the ASO administered soon enough? In the meantime, we at n-Lorem are continuing to work on advancing technology in a number of areas. And we certainly hope to be making better ASOs for people in the years to come. But that's basic research. It costs money and time, and it has to be funded. And we have to balance that between treating more patients today or making better ASOs for more patients tomorrow. And so that's all a part of the very same challenge, which is funding.
Yeah. To go back to this idea of getting a drug to a patient earlier, as you know, right? The problem sometimes is that the parents of the patient will hit dead end after dead end after dead end before they ever get a genome fully sequenced, and then they understand what the issue is. And I don't know how that hurdle is overcome, because as you said, it's expensive. Most people do not get their whole genome sequenced. So the way to identify the patients, I don't know if that can be done any faster the way our current healthcare system works.
Well, it's being done faster in lots of other countries. And the answer is really simple. Introduce whole genome sequencing into newborns.
At birth, right?
And it is not expensive. It will save billions of dollars in healthcare costs, billions of dollars in the first year. Just the amount of dollars, energy, and emotion wasted in trying to find a diagnosis. The numbers just boggle the mind. But the cost of treating a patient who is advanced is so much higher than preventing that patient from advancing. Look at SMA. When we began, we could only treat patients who were, the type 1 patients were progressing rapidly toward death at 6 months of age on average. Now we have many, many patients treated for years who began treatment before becoming symptomatic, and they look like normal, healthy children. How much money is saved, and more importantly, how much potential is created that would have been lost as those patients succumb to the disease. So I think actually it's going to be very simple to identify these patients early. All we have to do is drive whole genome sequencing into all newborns. That's happening in the UAE. It's moving along in the UK. It's happening elsewhere. And it has to happen in the US. And by the way, the more of that happens, the more competitive advantage countries will have in managing the health of their population. So it is also, I think, a competitive opportunity and threat for the United States. And we're certainly not leading the world. We're lagging, and so we're working on it. And the answer to getting it done is to demonstrate that you have a potential to treat. That's the first step. We think we've done that. Now we're working with others to try to drive sequencing into newborn screening, obviously with appropriate, protections for patient privacy and all that. But that is a solution. We have the technology to do it. We just don't have the will yet.
Yeah. The political will isn't there yet. Yep. So there's a couple of things I want to ask you to kind of finish out. And the first one, this is a little different from what we're talking about now, but I noticed that this year, you've been posting things, so like social media, et cetera, about leadership rules and not regulations, but like your guidance around leadership from your long history of, running R&D groups in big pharma, and then running a startup, and then a sort of medium-sized biotech in Ionis, and now a nonprofit. And I'm wondering if your thoughts on leadership have changed, in particular, since you've been running a nonprofit like n-Lorem.
No, they haven't. I think leadership is pretty much the same, no matter what. And I've been posting those things and science and a variety of other things because it's fun for me. And I think maybe there's some things that I post that will help others, I don't know how many or what. And I think the first step in leadership is to know what kind of leader you are.
Mm.
I now understand I'm a charismatic leader, and I'm a detailed-oriented, can be very dominating leader, and I have to recognizing that, and then making sure you take advantage of those strengths and take advantage of, and then buttress the inevitable weaknesses associated with their strengths is a part of, I think, being a good leader. And if you look at what I've done in my career, and I only figured this out very late, is I've really just been a dream merchant. That's all. I had a dream to reshape the way research in big industry is done. I got some of it done.
Mm-hmm.
I had a dream to create a technology that would change everything in healthcare, and I got it done. And my dream now is to take advantage of that technology to help a group of patients that are truly left behind.
Yeah.
So I guess I'm pretty much doing the same thing in pretty much the same way. I'd like to believe I've gotten a little better at it and have a little more self-control than I've had sometimes in the past, but I'm still Stan Crooke, and the weaknesses come with the strengths. So
Yeah.
no, I would say there probably are big differences, but not for me, because I've only done the things that felt like dreams that I really, really would care about.
But this idea that you have to know the kind of leader that you are, is that then kind of compared to what a good leader should be? You would have to know what a good leader looks like and then where your faults are and then combine those two.
Yeah, I think what the kind of leader that's optimal for a particular task depends on the task.
Yeah.
I would be, I think, not a particularly good leader for, running a well-developed retail business thing. One, you don't need somebody like me to do that. You need somebody who's going to block and tackle and do all the things that make sense. Somebody who will pay, who really is financially oriented. So I think matching the leader to the task is the first crucial thing. And I've had the opportunity to match what my strengths are 2 or 3 times in my career to a task. And could I run a retail business? Yeah, I think I probably could.
Would you enjoy it?
Would I? No. And would I do it as well as I do n-Lorem or Ionis?
No.
No, I wouldn't. And would anyone want to put up with me in one of those routine businesses? Probably not. Now, you don't need to shake your head about that, Brady. Just let me say those things. But yeah, what I am good at is finding a galvanic reason to work and collecting others who are galvanized by the same dream.
Yeah.
And organizing those people and demanding the impossible out of them every day.
Yeah. Yeah.
That's what I wouldn't be good at other things.
So the last thing I want to ask about, that's a great answer, by the way, but the last thing is the colloquium at the end of October.
Mm-hmm.
So I'm going to be there. I'm going to be having some conversation with some of the patients. And I wanted to ask you to tell me what else is going to happen over those 2 days and talk, I think a little bit, it sounds like some of the focus is going to be on what's considered like pioneer patients at n-Lorem. And I'm hoping you can talk about that.
Yes. Well, as you know, one of our objectives was to create a community for the Nano-rare. It's tough to have a community when you're only a person with a mutation. And so I've really worked hard at that, and putting the podcast series together was a big part of that.
Yeah.
These posts are a part of that sort of effort. And last year's colloquium was what was another step. And I felt last year's colloquium was wonderful success. And it was really a great pleasure and privilege to do it. So the question was, what did we want to accomplish this year? And I think, and we have, a set of pretty clear goals. First, we want to share what we've learned. That's really critical. We're publishing things. This weekend I spent rewriting, from referee comments, a big article that I hope will appear before very long in one of the major journals. But we're learning tremendous things. So we want to share what we've learned. We want to share not just what we've learned scientifically, but how to do this. What are the processes that we've invented? What are the systems and processes? We want to share all that in as much detail as people can tolerate so that others can adopt it, whatever works for them or not, or at least they know what to think about. That's really critical. Then we want to share what we're learning about the nature of these mutations and phenotypes in patients and how they're the same and different and so on, and then how ASOs are behaving. I'm going to share that in detail. So first, share what we learned. Second, listen. One of our real goals here is to have as many patients and families provide their stories, their feedback, their feelings about their lives, how these diseases have affected their ability to live a fulsome life, because it's not just the patient, it's the whole family that's harmed. And that's why, we're really excited that you'll be helping in that, because I think you'll get all that out of them.
Yeah.
Then the third is we want to highlight the extraordinary team we've built. In the end, everything depends on knowledge, experience, and the quality and integration of a high quality team. And I want to show off our team so that people know that they can come to us with confidence, and that they're not depending on me, they're depending on a really remarkable and strong team. And then fourth, we want to focus on the future and the challenges we face, which are principally funding. And so we'll spend some time talking about our plans for sustainability, our need to bridge to success there, which is, it's a real challenge for us. I mean, it's hard. When the budget starts getting into the 10s and 20s and 30s of millions of dollars, now you've got a real task. And so anyway, those are the things we want to talk about. And I'll probably weave in there some way or somehow the poetry of science and how poetry is the essence of life. But anyway, I don't know what I'm going to do about that, but this is about life. So it's a meeting about health and disease and how we need to begin to think anew, completely differently about health and disease. And so that's another big theme. So I think the first step to doing anything well is to know what you want to accomplish. And I think we've put an agenda together that will do that. It will have a good many folks from n-Lorem, but also all the other associated physicians, scientists, and so on that are working so hard for these patients and the patients and families. We are a collective, and we only succeed if we are a collective. And so I guess we want to take another step toward bringing that collective together and focused.
Yeah. The money problem, to go back to the money problem, it just feels like a good problem to have. If you were doing 3 INDs a year, you wouldn't have this money problem. But it's because n-Lorem has grown so fast that you have this problem. And in that way, I think it's the best problem you can have. It's because you're ambitious and it's growing quickly. So
it's the highest quality possible problem, and I'm happy to have it. I wish I had it solved. And so, we'll be asking people for their help. We can't do this alone. We're going to need everybody helping us. And I'm really thrilled so far. The registrations are way, way ahead of our first year. I think we're approaching 220 registrations already. And Biogen again is hosting it and supporting it. And this year we're able to have it at a hotel right next to Biogen, and that'd be much better, especially for our families with disabled patients.
Yeah. That's it, Stan. Those are the questions I had. I'm really looking forward to the colloquium, and as always, Stan, it's fascinating to talk to you. I appreciate your time.
Well, thank you, Brady. As always, you ask the right questions in the right way at the right time, and that's what makes you good at your job, I guess. So look forward to seeing you in just a month or a little bit more.
Yep.
Okay, thanks.
n-Lorem is a nonprofit committed to discovering and providing personalized experimental treatments for free, for life, to patients with genetic diseases that affect 1 to 30 patients worldwide, referred to by n-Lorem as nano-rare. Many of these patients progress and die without ever achieving a diagnosis. This is where n-Lorem comes in. They do the impossible by providing hope, and for those that they can help, free lifetime treatment. For more information about n-Lorem or today's episode, visit n-Lorem.org. Any questions can be sent into podcast@n-Lorem.org. Search n-Lorem on Twitter, Instagram, YouTube, LinkedIn, and Facebook to connect with us. This video is hosted by Dr. Stan Crooke and produced with the help of the following professionals. Thank you for watching.